For ankle dorsiflexion and plantar flexion, you can do this in either prone or supine, but you do want to make sure that the foot is off the table to allow enough room for that motion for the heel to occur without being blocked. Now, our landmarks are going to be a couple different ways that we can do ankle dorsiflexion. So our proximal is always going to be the midline of the lower leg or the shaft of the fibula. For some, you can use the lateral malleolus as your access. So I'm going to put my stationary arm here. And then what I'm looking for is I'm going to have to use kind of an access that's shifted here and make sure that I am parallel to the fifth metatarsal. So this one may be a little bit harder to perform because I'm not lined up directly here. So in this case, with dorsiflexion, I have to make sure that I am parallel to the fifth metatarsal. The second way of doing ankle dorsiflexion is I'm going to actually shift and use kind of a distal axis here, because really dorsiflexion is a combination movement as well. It's not just occurring at the talocrural joint, it's also occurring at the subtalar joint. And so what I can do if I want to use that fifth metatarsal and line up my movable arm here, I still have my proximal arm going through the malleolus and up the lateral aspect of the leg. But now I'm shifting and using that little bit of a distal axis here. So now I can ask my patient to bring her toes up towards her nose. Make sure that I reassess my alignment and that I'm aligned properly in these positions. I can then do my passive range of motion, which I'm not getting a whole lot more here. And then come in, stationary hand, movable hand. Take up that extra physiological range of motion and give that end feel and see what that feels like. It's a very, very firm, so it's almost that firm to kind of, not necessarily hard end feel, but definitely a much more firm end feel. Normal range of motion is considered 20 degrees. What you'll find is that a lot of patients have a lot of difficulty obtaining 20 degrees of motion. Plantar flexion, I can do the same thing. Use my axis as lateral malleolus and parallel to the fifth metatarsal in here, or again, I can come down here and kind of shift my axis down. Here I'm going to ask the patient to bring their foot to the floor. One of the other things now is look at the toes here. And so basically you see this person is getting this curve here. I want to make sure that I stay aligned with the fifth metatarsal here. I don't want to line my movable arm with the toes. I want to make sure that I stay with the fifth metatarsal. And so in this position, I'm going to read what my goniometer says here. Remember again, in this position, I'm starting at 90. And so I'm going to be reading a different set of numbers here. And then I'm going to do the passive range of motion, recheck, make sure everything's aligned, double check my proximal alignment. And then I want to do my end feel, which again is going to be a firm, switch hands here so you can see, it's going to be a firm end feel for plantar flexion. Normal range of motion is 50 degrees. When we talk about inversion and eversion, in this particular case, in a prone position, we're going to be measuring subtalar motion. And truly, inversion is a combination of supination, abduction, and plantar flexion. One of the first things we want to do in this particular position is take the patient's other leg and put it up in a figure 4 position. And what that's going to do is it's going to make sure that our hip is not externally or internally rotated too much, which is going to change the position of my foot. So it puts them more in a neutral position when they're in that figure 4 position. Now for inversion, My landmarks are going to be the fulcrum of the goniometer is going to be over the posterior aspect of the ankle, midway between the malleoli. So here's my two malleoli. So my fulcrum is going to be at a spot midway in between there. My proximal arm is going to be the posterior midline of the lower leg. So I need to make sure that I'm going directly up the lower leg. And my distal arm is the posterior midline of the calcaneus. So I'm going to draw an imaginary line through there, or you can go ahead and draw a line on someone. So here are my landmarks, and I'm going to ask the patient to turn their foot in, relax for a second. And I want them to come more directly in this position. I don't want a lot of super plantar flexion there, so we're going to come in with this direction. And I'm going to realign my landmarks here and take my measurement, which I have 27 degrees. And then I'm going to do my passive. I can get her up to 30 degrees. And then I'm going to do my Enfield in this case, which for inversion subtalar is going to be firm. Normal range of motion is 20 degrees. For eversion, my landmarks are going to be exactly the same, that midline that's in between. And we're going to have my proximal arm up the mid aspect of the calf, and then the midline of the calcaneus, and we're going to ask the patient to move out. Now, if you notice here, there is not a significant amount of subtalar movement in eversion. And most people are very limited in subtalar eversion. And we're going to take that measurement, and we have 6 degrees. We're going to do passive, which I'm not really getting a whole lot more, maybe 1 or 2 more degrees. And then I'm going to come in, get my nice firm stabilization hand, and do my Enfield. And in this case, the normal Enfield is hard, mainly because of the contact between the calcaneus and the floor of the sinus tarsi. So it's definitely a lot harder. It feels like it can't move. It's not firm like inversion is. Another way to measure inversion and eversion of the foot is to measure all of the tarsal joints. So remember, with the patient in prone, we are actually doing subtalar range of motion. In this case, we're measuring all the tarsal joints together. And again, this is a combination with inversion of supination, adduction, and plantar flexion occurring in varying degrees at the subtalar, transverse tarsal, and several of the tarsal joints. So in this case, our fulcrum is going to be the anterior aspect, but we're still going to be midway between the malleoli. The proximal arm is going to be up the midline of the lower leg, and the distal arm now is the midline of the second metatarsal. So midway between the malleoli, the second metatarsal, and the midline of the lower leg. And we're going to ask the patient to turn their foot in. Remember to realign, don't align with the toe, align with the second metatarsal. And we're going to get a reading here of 50 degrees. And our passive, we're up to 56 degrees. And our Enfield is going to still be a firm Enfield. In this case, typically the tarsal range of motion is 30 to 35 degrees. So our patient had a little bit extra motion in through there. With eversion, we're going to have the same landmarks again. And now we have a combination of pronation, abduction, and dorsiflexion. And we're going to ask the patient to move out with the same landmarks. In through here, I've got 23 degrees. We're going to do some passive motion with the forefoot. I can get her up to 28 degrees, and then we're going to stabilize and do an Enfield. And again, it may feel hard or firm depending on the contact on that lateral aspect. Normal ranges of motion for tarsal eversion or forefoot eversion is 15 to 20 degrees.